weird stuff when the nerves go wacky with head and face pain. So if anything else that you think of that I don't cover tonight, I welcome that for questions. So for starters, how many of you came tonight because of neck pain? Just curious. Okay. All right. So basically with neck pain, a lot of the originating issues can be the discs. So that's what's in between your vertebrae and your cervical spine. And you need to be mic'd up for sure. Yes. Okay. Sorry.
No worries.
I started without you. So again, neck pain can come from a lot of different structures in the neck. So your discs, your facet joints, if you don't know what those are, they're basically, I'm going to just kind of hover over them there in the back of the neck, and they basically allow you to kind of bend forward and backward, side to side, and rotate. So I don't know if you've heard the term facet joints, but they're basically right there, and they have a little disc in there. They can get arthritic, they can get swollen, and then besides discs and joints, has anyone heard the term stenosis or been told they have stenosis? Okay, so stenosis is narrowing where that nerve comes out. So those nerves exit the spinal cord and go down your arm, and so if it's already a pretty small opening. So if it narrows, what do you think happens to the nerve? It gets irritated, it gets pinched. So that stenosis can be an issue. The nerves, obviously, if they get pinched, whether that's through stenosis, or let's say you have a herniated or protruding disc, which is what that is trying to show there, that can press on a nerve. And then the muscles around the area, if they get tight or they go through an injury like a car accident or a fall where you get jostled around, the muscles can get really tight and they put pressure on a nerve as well. So a pinched nerve could be caused by a couple different things. You could also have a bone spur from arthritis as well that's pinching a nerve. So there's just a lot of options for the quote pinched nerve. It doesn't really tell me, when someone comes in with that diagnosis, it doesn't tell me what is causing it. It's a little bit of like, okay, we will figure that out. So that's that slide, just a little bit on neck pain. I think it's good to go over disc anatomy. How many know they've had a herniated disc or a degenerative disc or a protruding disc, anything disc-wise? Yeah, there's usually, it's pretty common. And the really interesting thing too that always makes people kind of pause is basically if we took a bunch of people out in the population that are not having neck pain, they're not having any neck pain, and you put them through some MRIs, a lot of them have disc problems, but they're asymptomatic. So, just in our world, we can't order imaging. We'll look at it, we'll look at the report if you get it, but a lot of times I just table that. Like, it's like, okay, that's what the imaging says. How is this person actually functioning in front of me? Because that matters more to me. If you're not sleeping, if you can't turn your head to the right, those are things I can have impact on, and sometimes the MRI correlates with what I'm finding, and sometimes it doesn't. So it's just kind of interesting that you don't want to put all, take your imaging with a little bit of like, all right, does that match up with what my problems are? Because sometimes it just creates more anxiety, some of the imaging results. So the disc, you can see right here, if it's bulging, it's going to kind of hit on that nerve. And then this is trying to show a bone spur, and that will hit on that nerve. So just kind of two different ways that you can have a pinched nerve. So that's the stenosis issue when that is narrow. Now nerves also refer pain because the different nerves as they exit correspond to different regions in your arm. So sometimes people come in and say, I have a shoulder problem. And any good PT and any really good ortho will do a neck and shoulder screen, because sometimes we really don't know. You could be like, if you could swear it's your arm, and then we do our test and it's like, what's coming from your neck? It's not actually coming from your arm. So C5 tends to be right there on the side of the arm. You can also see it'll give a little bit of shoulder blade pain. and sometimes down to the elbow, and then a little bit in the neck. So that's C5. So the neck is, if you don't know, is they just number the vertebrae, right? C1, 2, 3, 4, 5, 6, 7. So that's how we come up with this fun, logical way to find the nerve patterns. So the C6 tends to go down even further and get into the thumb index finger sometimes. So depending on your pain, we can kind of figure out which nerve it is. So there's C7, there's C8. So it's just interesting, sometimes people are like, it's my shoulder blades, my shoulder blades, my shoulder blades. Like, let's do some tests to actually see if it's coming from your neck. So there's definitely a way to rule that stuff out. So just kind of be aware that nerves and pain, where you have pain isn't always the source of pain, is my point with that slide. All right, common causes of the nerve pain, we kind of went over this: herniated disc, bone spurs, stenosis, degenerative disc. Spondylolisthesis, it's a bit of a mouthful, but one vertebrae is slipping forward or backward on another. So it's an instability problem, but you can see if you had one of those vertebrae actually moving forward or backward, how that would probably pull on that nerve and create a problem. Oh, and I did put it in here. Important to note that 88% of asymptomatic people have these findings on imaging but have no pain. That's a lot. I mean, that's more than half. So, if your imaging is normal but you have pain, don't worry. Like, it's probably something that just can't be seen on imaging. A lot of soft tissue things that are going on. The ligaments and irritation can still be there. There can still be a reason for your pain, even though the imaging may not show it. So, just kind of an interesting side bit there. So pinched nerves, like a lot of times people think, well, I must have to have an injection then to solve that, like physical therapy. What would physical therapy be able to do? So our approach with that is often to try to unload that nerve with some of the hand techniques that we do. If the muscles are really guarding, massage, dry needling is really good to help those muscles let go. Shockwave is another newer regenerative therapy that can help with trigger points, especially if someone really is needle phobic and doesn't want to try the dry needling. Shockwave is really good with trigger points as well. So there's a lot of ways we can, with physical therapy, impact unloading that nerve. And there's things we can do to get you better faster now that we didn't have before. So, and I'll get into that tonight with some of the regenerative services. So, here's a picture of a couple of them. So this is EMTT, which is magnetic therapy. It's about half the strength of an MRI. Shockwave, that they're just trying, you don't actually see this part, they're trying to show the energy coming out of the shockwave machine. And then this is StimPod, which is pulsed radio frequency. So those are all part of our regenerative therapies to help with pinched nerves. So let me kind of walk through them a little bit, because that probably sounds like a lot. EMTT, extracorporeal, just means outside the body. That's all that word means. Magnetic transduction therapy, so it's using magnetic waves. And it really reduces inflammation dramatically, and it stimulates nerve regeneration. So I've had some really, really irritated, herniated discs where the person could hardly stand, sit, hardly function. So they say their pain was like a 9 out of 10. And then after about 3 weeks of using EMTT, they got it down to like a 2. So it doesn't solve it right away, right? Not like an injection or taking, some people opt for taking the prednisone to really knock down their inflammation fast. But it does a really, really good job, but it has to stack on itself for about 3 weeks for you to really feel the difference. So it's been great to see how it clears up inflammation post-operatively with people, and then also just a different option instead of an injection, because that's a lot of times people feel like all they're left with a pinched nerve or a herniated disc. Depending on how big the herniation is, sometimes you still need surgery. So I myself had to have surgery for that. So I've been there, done that, and even now that these therapies are here, they weren't available when I had my issue. I still think mine was pretty large, that I don't know that this would have been enough. And when I've had other patients come in asking, like, hey, I really want to make this work and avoid surgery, and I look at how big that herniated disc is and how significant of the nerve impact in that leg. So this person had like absolute foot drop. Do you guys know what that means? They couldn't pick their foot up at all. And it was basically like you really, based on where this herniated disc material is in the center, you're better off having a surgery. So, you know, I'll level with people. I'm like, I don't know if this is gonna make it work. So sometimes you still have to have surgery, but there are a lot more options now than there used to be, and you can get better faster, in my opinion, with some of this stuff. StimPod is pulsed radio frequency, and if you've heard, has anyone heard of like nerve ablation, like radio frequency for nerve ablation? So that's continuous radio frequency, which will kill the nerve, ablate it, tell it to just stop working. This is pulsed, so it's not cauterizing the nerve. It's trying to basically heal and decrease that sensitivity of the nerve and get it to function normally again. So pulsed radio frequency is still the same technology, but using it in a way that won't ablate it altogether. So that's been really neat to see bring, you know, people that have had years of the tingling, numbness, etc., peripheral neuropathy. But with our pinched nerve people, like an acute injury, they just get over a little bit quicker if we do the StimPod and the EMTT together. That's like wonderful. In fact, my sister's a nurse, and she was walking her dog. She's younger than me, golden retriever puppy, really energetic. Pulled her and she fell, you know, so it like gave her a stretch injury, and she thought she was fine until a month later all the nerve symptoms came on. And for a couple months, she didn't tell me anything. She doesn't live here, she's in Texas. A couple months went by, and she wasn't really telling me what was going on, but finally admitted to what was going on and saying, well, I already went to physical therapy, that didn't do anything. And I said, well, I'm going to ship you this unit, and I'll talk you through how to use it. And basically, within a week, she was off her gabapentin, off her, you know, NSAIDs. It was probably about 40% better, and I found somebody nearby that could do EMTT and shockwave. She added that in, and within 4 weeks, she was 75% better. She went for about 4 months, no progress, thought she was gonna have surgery. She's young, she's healthy, and she's a nurse. So she's like, why doesn't everybody know about this stuff? I'm like, that's a big topic. Yeah, well, our healthcare system, I mean, in the US, doctors know how to do cortisone shots, they know how to do procedures, they know how to do surgeries. This is a different animal, and I just think until the public really demands it, it just doesn't quite fit in the same box, and insurance doesn't pay for it, right? So there's a whole host of reasons. Those are just a few. But it is becoming a very standard practice to use these things over in Austria and Germany. Shockwave in particular is becoming a standard of care with cardiac surgeries. So that ischemic heart, like after a heart attack, when that part of the heart dies, when they're doing bypass, now they're doing shockwave to that ischemic heart, and that will start to repair itself, and they'll see that evident later on down the road, which was unheard of. So it's becoming that way, and I think Europe's going to lead the charge on that, and then US will slowly follow. Focused shockwave is also another way to stimulate the nerve and heal, and it also helps with, like I said, with trigger points with the muscles. So right now, my main attack with nerves is EMTT and StimPod, and then sometimes I'll add the shockwave in too. So it just depends on where the person is in their journey and how over it they are, of how many things we're going to throw at it. So it kind of depends. Okay, so we're just going to go through some practical tips here. So I want everyone to kind of freeze and tell me if your ears are in line with your shoulders, meaning if I look out of my peripheral vision, I can see the front of my shoulder. If I'm a little bit slouched, I can no longer see that. So it's kind of funny when you're sitting, if you're like, okay, are my ears in line over my shoulder, or am I a little bit forward? So just a little check. Forward head posture is the leading cause of disc degeneration in the cervical spine. So that's why I kind of make a big deal about it. And if you can see, like, I mean, her head isn't way out there, but it is a little bit forward. And when your ear is right over your shoulder, you can see how these muscles they're just relaxed. They're not they're not holding a bunch of weight. But as soon as your head goes forward, you see how much more tension and work those muscles are going to have to do. And if you're one that constantly is rubbing your neck, probably you have a little bit of forward head posture. It's really hard not to if you work on a computer for any length of time, or if you use bifocals, trifocals, etc. There's a lot of that head movement going on. And the head weighs 10 pounds, and so every inch forward, you place 2 times that force on your neck and muscles. So it is something to just be aware of. So I want you to try this for me. I want everybody to slouch. So just give me your best slouch if you can. And then I want you in that slouch position to try to turn as far as you can to the left. And note how your neck feels when you do that. And then turn all the way to the right and feel how that feels when you do that. Now I want you to sit up really straight, and I want you to repeat that. So then turn all the way to the right, and turn all the way to the left. And what do you notice comparing those two things?
Really different.
Yeah, you have way more range when you're upright. Yeah, so when you're slouched, you should almost feel like you get jammed, right? So that's the point, is to kind of notice what it does, and over time you can lose mobility in your neck from incorrect posture. So this one I like to show too, just like I showed how referred pain with if you have a pinched nerve at C6, C7, how it radiates down the arm and the shoulder blade. This is if you have a lot of tight muscles in the neck, how it can refer pain up around the head and behind the eye. So these little X's here, those are trigger points in the upper trap on this image. So those trigger points would refer pain typically up the side of the neck and then around the side of your head to behind the eye and even to the jaw. So same with this one here. This is a sternocleidomastoid muscle that often is a culprit for lots of issues. But you can see kind of the variety. Some people will swear that their jaw is the problem, and it's really coming from the muscles in their neck. I had an office manager at one time who fell a couple of times, and so of course we're thinking it might be a stroke, right? So she gets that ruled out and everything. I don't remember what all they checked, but a whole bunch of things. It ended up being trigger points in the SCM that was causing dizziness and her falling. So it's kind of one of those weird. It's a weird muscle because it can even create ringing in the ears. It's one of those muscles with trigger points that can create a whole, jaw pain, headaches, ear ringing, dizziness. So if you don't believe me, you can go look it up in ChatGPT if you want. But it is one of those weird ones. Dry needling and shockwave can help with trigger points. And then also just going through, like, I don't know, maybe there's something during your day. If you have 2 monitors, you tend to work with 2 monitors. Do you have one that you tend to really turn to quite a bit? So reducing the amount of rotation that you're doing. So really looking at your daily habits that maybe you've gotten away with for years that are stacking up against you. TMJ just mentioned, does anybody have a little bit of jaw, facial stuff? Okay. Yeah, it's often a combination of the neck and jaw. And I want you right now, just check where your tongue is positioned in your mouth. And just take note of where that is. Because, and where it's touching and what it's doing, it really should be on the roof of your mouth, right behind your front teeth. If it isn't, that could contribute to more tension and tone in the face and in the neck. And then if you're a mouth breather, that's also going to contribute to more tension in the jaw and face. And so if at night, if that's what you do, that could be a hard one because maybe you have sinus issues or allergy issues. I usually always ask my TMJ people, like, if you do have problems breathing through your nose, are you seeing an ENT or an allergist? Like, do we need to get that on board? Because I could do the best PT, and if you're still doing this, you're going to kind of keep living in that cycle. So I have some options if that's an issue. And then if you slouch for me, go back to slouching, where does your tongue just naturally want to go? It doesn't want to stay on the roof of your mouth, does it? It drops. Yeah, usually it drops to the floor. So again, then that makes the tone and the muscles and the jaw just have to work a little bit. So that forehead posture is a real problem. You're not picking up on that. So this is a nice picture. I know you can't read all the words on it. You'll get the slide deck. But it's trying to show some of the muscles here and the temporalis muscle here and all the neck muscles, and just, headaches, head pain, forehead, you get pain around the eyes, mouth, teeth, like just all these things. If that area is just in tension and you don't have great posture habits, can create a lot of issues. So I thought that was kind of a good graphic, so I threw that one in there. All right, so really I think you're getting it. The number one thing people do that causes neck pain and headaches is forward head posture, and these are just some of the reasons. Tablets, smartphones, computers. I hope you don't read in bed. It's just really, it's almost impossible to have good posture in bed. It's just really, really challenging. So if you kind of like to snuggle up when you read before you go to bed, can you be in a chair with a heated blanket or something? Can you find an alternative? Because reading in bed is pretty hard on the neck and the low back, to be quite honest. And then TV, if you watch TV with the screen, I don't know if they do that anymore, but that was for a long time when houses were being built. It seemed like everyone was putting the TV above the fireplace and everybody was doing this. I don't feel like I see that quite as much anymore, but pay attention to your habits and where things are positioned and how you're watching things. And if you sleep with more than one pillow because you have reflux or whatever, it also is just another thing that can drive your posture forward. So, and then occupation-wise, looking at your desk and computer work. So all those things add up over time. Posture, if you have kyphosis, which is that rounded upper back, it just kind of contributes to also thrusting your head forward. So doing postural stretches, trying to prevent that would be what we would advocate for. We just put measurements here. If you stand against the wall and can't get your head back to the wall, you're probably already rounding a little bit. And then if you were coming to PT, we often take that measurement. So that's kind of what those are. Yeah, see that beautiful posture we got going on? So avoid that. If you slouch again, I know I'm asking you to slouch, but you're going to slouch again. And then I want you to raise whatever arm you want as far as you can in front of you. And then repeat it with good posture. And you should kind of find the same thing we found with the neck rotations. When you're straight, you can go a lot further with your range of motion. So it impacts now, when you slouch, your shoulder ability and range of motion and how the rotator cuff functions. And basically you run into impingement sooner, and it can lead to more micro tears. So anyway, it'll start to affect shoulder. I'm not going to do a deep dive into that tonight. So forward head posture, I think we've kind of hit that nail on the head pretty good. There are some really good quick things to do throughout the day, like shoulder blade squeezes. Just if you're there at the computer for a while, just trying to do that, just to get out of this. That's a great one to do throughout the day. A little bit of chin tucks, right? And I'm not doing this, right? I'm just trying to bring I kind of just visualize that wall behind me. I'm just trying to bring my head back to the wall because I've probably been doing this. So it's a chin tuck, shoulder blade squeezes, the doorway stretch where you just put your arms on the door frame and just kind of gently walk through, and you're just trying to stretch this because I've been like this all day. So it's, the opposite of this is what you're doing, just trying to open up your posture. So those three, if you can just make those intermittent habits, if you've been there for a little while, that would really help. All right, now I'm going to get into some fun, not so fun, more of the head and face, kind of just pain things that aren't very common. They're very hard to manage if you are a sufferer from one of these things. So first one I'm going to tackle is trigeminal neuralgia, and there are a number of causes, right? But the number one thing basically is there's pressure on the trigeminal nerve, and usually it's by a blood vessel exiting at the brainstem level. So from back here before it even gets to there, which then when you have compression on a nerve, that wears away the protective coating, and then it just starts to flip out. I mean, the nerve just really, it's very painful. People who have trigeminal neuralgia usually have a lot of pain shooting into these distributions, right? So there's not a lot of options for people. There's obviously medication. They'll try to do a nerve ablation, like the radio frequency that I talked about, and then like a surgery if they need to do like a decompression surgery to it. So what we have been doing, and there has been some randomized controlled trials as well showing this can be helpful, is using that stim pod, which is the pulsed radio frequency, to the 3 branches of the nerve. So we'll put it here, here, and here. And I just think it's a little bit variable on success, depending, probably, my guess is how much compression is that nerve undergoing, right? I mean, if it's structurally really compressed, even when I do the pulse radio frequency on those nerves, it may only temporarily alleviate it. So it kind of depends. I think the ones that are successful probably aren't caused by a lot of compression on that nerve. Questions on that? Does that make sense? Go ahead.
Yeah. So if you have the type of, or maybe it's not all that way, but if you have trigeminal neuralgia, and like you have it for a while, and then it kind of like recedes into the background, and you don't have the pain or not very much pain for a while, then it surges back up. Do you get the treatment while it's in its surge phase, or do you?
Usually that's when people are seeking treatment, right?
Usually, yes. But
yeah. So usually I don't have anybody coming in when it's not.
Yeah, my son, that's when you would do it, like maybe when it first like starts back up or something.
Yeah.
Okay.
Yeah. And if it comes and it recedes, it also makes me just wonder, like, the pressure on that nerve must be related to inflammation, maybe, or stress, and not so much a physical structure that can never be changed, right? Because it doesn't make sense to me if it was really a structure, an anatomy structure that had constant compression on there,
Right.
it would stay,
Yeah.
right? So to me, I'm like, to me, if it comes and goes, I would think maybe this pulse radio frequency would be like you would have a better prognosis solving it for longer. What else? Yeah, any other questions on trigeminal neuralgia? Yeah.
Is the pain mistaken for like a headache?
I'm going to get into headaches. Yeah, so different. It's different. Trigeminal neuralgia is usually,
It feels more like a taser.
yeah,
Shocks.
yeah. I was going to say this is going to be sharper and not.
Or burns, it changes, but sometimes it burns like fire, sometimes it shocks.
Yeah.
Yeah.
It's just crazy.
Yeah, I'm like, I'm never confused. If it's headaches or trigeminal neuralgia, it's like, that's pretty obvious. All right. Okay. Bell's palsy is the facial nerve, very close, like trigeminal. Kind of, if I go back a slide, you can see they're very close in proximity. All right. So Bell's palsy usually comes on after like a virus. The person's face will kind of droop. They can't close their eye. It's very distressing to them to go out in public and not be able to, that face just looks like everyone asks them if they had a stroke, right? And it usually resolves over time. But the great thing about using the stim pod is we can put that on these different branches. So I usually am hitting here for 5 minutes, this 5 minutes, and this 5 minutes. And usually within a couple of weeks, they're like almost all the way back. So it works really quickly. And they're usually, they're just very happy because it's one of those, like, they didn't let time just carry on for it to eventually heal. So that's that one. That one's pretty straightforward. I just don't think many doctors even know that this even exists. Like, you can do pulse radio frequency in the outpatient setting. They've heard of it. If you ask them if they've heard of pulse radio frequency, they've heard it, but it's only been in the surgical suite. And the code to bill it is in the surgical codes. So what do you think happens when a physical therapist tries to bill it? Red flag. Yeah, you're not authorized for that code. Like, I understand why the code is in that category, but I promise you I'm not doing surgery. So they don't pay for it, but they'll pay for it in the surgical suite, which is then thousands of dollars. But, I mean, like, you have to have anesthesia. Anyway, and they won't always do. I mean, they probably won't do pulse radio frequency in the surgical suite for Bell's palsy. There's certain things that they have done before, but I doubt they would for this. Because they know, like, they just give it time to resolve, right? Okay, burning mouse syndrome. It's a malfunction of that trigeminal nerve that we already went over, of the mandibular branch. They don't really know why, for some people, why this comes on. Sometimes stress. Things that you can do to prevent it is, like, you don't want to be deficient in your vitamin B's, particularly B12, folate, and iron. But there is a lot of, infections could potentially cause it. But there's also just a lot of, like, we don't know. Basically, this something goes haywire, and it's very, it's distressing. I mean, your mouth burning. Does that sound like a great option? No. So we can stimulate the probe of this. You can see that if this is the stim pod unit, the very, very end of it is this, like, a metal probe, and we just stick that on the tongue, and you can move it around. So we kind of do that for 5 minutes there. We also get the trigeminal nerve, and then we also do a little bit like the ganglion anterior to C6, because that's just kind of where the nervous system just needs to be calmed down. And then we also stimulate the vagus nerve. So there's a lot there, but we basically don't understand exactly why people get burning mouse syndrome, but it is awful. Does anyone know anyone who's ever had that? It's an interesting one. Occipital neuralgia is these nerves on the back of your head that get compromised. So we would use the stim pod to the greater occipital nerve, the lesser occipital nerve. It's sharp, a little more, again, it's different than headaches. It's a little more piercing, electric. Kind of what you would think when nerves are involved, right? Pain along the face of the neck and can radiate to the head and behind the eyes, but it is sharper in nature than just a headache or a migraine. I like this diagram because you can see all these muscles and nerves and blood vessels. I mean, there's a lot back there at the back of the head. And if you think about forward head posture, how that compresses everything there in terms of the blood flow and the nerves, that's why a lot of the manual therapy is very helpful to open that up back there, and just why forward head posture can put more stress on that area. So now I'm going to get into headaches. There's kind of 3 categories. One is, we call it the cervicogenic headache. It just means it's coming from the cervical spine, especially the upper cervical spine, so C1 to C3. And that pattern starts deep in the neck. It radiates to the occiput, which is like the back of your head, and then to the temple side, and then behind the eye. It's dull, it's pressure-like, it's not pulsating. Triggers, things that bring it on, so like neck movement, or like a sustained posture for a long time. If I palpate over those facet joints, sometimes that brings it on. It can spread toward the shoulder and upper back just due to all the tension. So the key difference is that, like I said, occipital neuralgia, the pain is sharper and electric-like, and often triggered by touch or compression over those nerves, not so much by neck motion. And then a tension-type headache is often on both sides, pressure and tightness of the scalp, the neck muscles, not nerve-related, often described as a band around your head. Triggers, stress, fatigue, not sleeping well, posture. It's kind of steady and more global. That's how we would put the tension headache. And then the migraine with occipital pain, right? So migraine is believed to start with kind of abnormal electrical activity in the brain and how it processes sensation. And then that triggers a reaction in the head's nerves, the trigeminal system. This is the third time I'm talking about the trigeminal nerve tonight. And all the blood vessels there, leading to kind of a temporary dilation of the vessels and inflammation, and that causes a throbbing pain. So this is more of throbbing. Often starts in the occipital area, the back of your head there, and it's throbbing, often one-sided, and usually associated with nausea or like a sensitivity to light. That's the photophobia, or like an aura. So the key difference is the migraine is pulsating and more systemic, while occipital neuralgia is more focal and stabbing. Nerve blocks will relieve the neuralgia. If you have occipital neuralgia, that's one way they treat it, but it won't relieve like a true migraine. Okay, before I keep going. Back up. Any questions on the headaches, migraines, occipital neuralgia stuff? We found with a lot of the headache stuff that the dry needling is very helpful, our manual therapy is helpful, and then using the stim pod on those nerves, like the occipital nerves in particular, can be helpful with occipital neuralgia, and some people just, in terms of the migraines and bad headaches, if we're not getting enough results with the hands-on therapy and the dry needling, then also trying the stim pod a little bit is another option. Shockwave, if someone doesn't like needles, like I already mentioned, we can use shockwave for the trigger points instead, and that can be really, really helpful, and it increases blood flow to the area. So a couple different options with that. All right, so just strategies with your neck and head pain. I think you got it, that like you want your ears over your shoulders, correct posture. Try not to sit more than 20 minutes at a time. If you can set a timer and get up and move around, you'll do a lot better. Sit with lumbar support. If you sit with lumbar support, your head automatically kind of just does the work for you to sit up better. So try that, especially if you have a seated job or a long seated task that you're going to do. Try to sleep with just one pillow. Never read in bed. Get yourself a heated blanket. It's the best thing I ever did. Cozy up in a nice good chair with good support. Don't fall asleep sitting up. And then stretch several times a day. That doorway chest stretch. Squeeze your shoulder blades, chin tucks. Those are like my fave. Do them a lot. And then posture. Yeah. I mean, Pilates is great if you're into like I want to do something to help with my posture and core. We power Pilates classes here that people really like, and yoga as well. I'm a big fan of that for stretching and posture and breathing and just down regulating the nervous system. So if you're a real tense person, you're figuring out how to bring that down. So I kind of went over this already. Oh, I don't think I mentioned this. If you do a deep dive on the literature, and we incorporate this in PT when you're here, but people who have chronic neck pain and headaches, they're usually very weak in their deep neck flexors, which is not these big muscles that you feel tension in, but they're behind your throat. The muscles right on top of your spine are your deep flexors, and they give you a lot of stability to your neck. And when we work those and your postural stabilizing muscles, you have usually less neck pain and headaches, and that's what the research supports. So this is a whole thing to learn how to do correctly without activating the wrong muscles, because most of us, if you're already tense, it takes a while to calm down the overactive muscles and then get you to use the deeper ones. So that's a big component once we can bring your pain down and your tension down. And then just this whole like calm down the nervous system, right? Diaphragmatic breathing. I mean, there's a reason why all these smartwatches tell you to breathe. It is based on data. So to wrap up, and then we'll get to Q&A. On that form that you were given, you probably fit into one of the two categories typically, right? You have neck pain or head pain, and it's stopping you from doing things, or maybe it intermittently bothers you and prevents what you want to do. Really, to give you a full, what is all involved, getting a PT evaluation would be the best step, because then I really know which muscles are involved, more so than anything else. So a personalized PT plan, and then which advanced technologies would help you, if any of them, right? I mean, maybe it just be PT and maybe dry needling if you needed that, And if you really are having a hard time, like the pinched nerve stuff, the neuralgia stuff, then more than likely we're going to say this would help get you there faster. Your choice, but this is what we have available. If you're already doing physical therapy and really you're just looking for other options besides surgery and cortisone shots, then having a consult about our advanced technology would be the other thing I'd offer. And if you're just here to gather information, then that's fine. I guess you'd be a C where you don't need anything at this time. At least you know what's available. So, if you fill out your form and you want a copy of my book, you can have that. But let's take questions first. And I also probably should check the chat. Or Zoom people. See if there's any questions. All right, Zoom people, if you want to, you can type your questions in there. I don't see anything at the moment. But I'll take questions. I'll try to remember to repeat the questions so that they can hear it. So anybody have any questions?
So what parts of what you described may be covered by insurance and what is clearly not?
What physical therapy is, right? Dry needling, unfortunately, like with Medicare, they'll pay for dry needling by a physician. How many physicians do you know want to do dry needling? So they won't pay for it by a PT. So that's an add-on. And then the stim pod and shockwave and EMTT, they're all considered regenerative. And if you actually read like Regents, Primera, any of them, they all pretty much say this is experimental. And it's like, well, there's a lot of evidence becoming standard of care over in Austria and Germany. So that's just where the U.S. is on it. It's behind. So it is. But we have created packages and different recovery plans. If you're going to opt into more than one of those services, we've kind of made it where, like, all right, this makes the most sense to make it more affordable. Almost like it's a 50% off if you upgrade to the premium plan, because some of our people are going to opt into three things. So, but we still have the a la carte pricing if someone's like, well, it really only makes sense for me to do one thing. Yeah. So, trying our very best to get everybody what they need in as much of an economical way that we can do. Yeah. So I just think it's going to take a little while for the U.S. to catch up. So, I mean, one of the researchers, his last name is Gerdes Meyer. I don't think I had him on any of the articles today, but I've talked about him before. He's a German orthopedic surgeon, and he had his knees were scheduled for a total knee replacement, and they did the EMTT twice a week for 4 weeks, and they canceled their knee replacement surgery because EMTT was working that well. So, I mean, this stuff is pretty amazing. I'm grateful for it, grateful to have it. So, I have my own pinched nerve story, which, well, I'll let you guys ask some more questions. I can tell stories forever. But anybody else have questions tonight that they came with that? Yeah.
I had a concussion a few years ago, and so I get more attention headaches. Have you heard anything since? I think you talked about.
Yes. Yeah. So concussion and tension headaches. I think back when we had just barely on some of that technology in our office at that time, but they are using the EMTT for concussions, and it's not published yet, but when I went to the Regen conference, there was a lot happening with shockwave and EMTT for MS and for Parkinson's that is going to be really exciting. And the EMTT and the shockwave they were doing to the actual brain, right, and seeing amazing results. I just don't have protocols yet on some of that stuff. So my question now would just be like, do the doctors think the tension headaches are coming from actually the brain issue, or just tension from the neck, right? Is it more, because when your neck takes a bit of a beating, if you will, of concussion. So is that headache really just coming from the cervical soft tissues being tight, or is it really the brain still creating that headache?
Well, it's so tough because the MRIs didn't show anything on the brain.
Right.
So they didn't use the tomograph side.
Right.
But still, I know better than anyone else that the headache exists. but it's really hard
Yes,
to prove it.
for sure. Yeah, and I just wonder at this point, how tender the neck muscle, if the neck isn't really tender, then I'd be like, well, then it's coming more from just the brain still. But the EMTT has been something that has been helpful. So that's what I would lean towards trying the EMTT.
I have a question for insurance, maybe someone that has already experienced some of this might
Go
might
ahead.
answer. So can you self-refer for physical therapy?
So for physical therapy in the state of Washington, by law, you can come directly to us. However, if you're trying to have your insurance pay for the physical therapy, your insurance may require a referral.
I see,
So that's the hiccup.
I see.
Some of them don't. Some of them are like totally fine. Refer yourself, and they don't require that. So it depends on your payer
I
to
understand.
answer you that way. Yeah.
Okay, but then for the alternatives, I can just come in and say, set up I don't have to I don't have to do the physical therapy
Right.
first.
Yep. So in that case, let's say, because we get some people that are just coming for shockwave or for just for stiff, like, I mean, like, let's face it, like, burning mouth syndrome, there really isn't anything physical therapy that I have to offer you other than the stim pod. So that person will get scheduled for a 40-minute consult just about that and a screening to make sure that that modality is appropriate. They don't have any contraindications to using that. And then we'd set up the course of treatment, and it would just be cash appointments for that. So, yeah, they're coming just for that. We'll just schedule you a consult regarding that, and insurance doesn't even get
Involved.
involved.
Got it.
Yeah, so that's allowed. But
I just wasn't sure.
liability-wise, we require doing, because we got into this with somebody, if you can believe this, but no, I when I come in, I want just to put the shockwave on this hamstring. I just want that. I don't want to have a consultation. It's like, okay, legally, I am required to check you and make sure that it's okay and that I don't do anything to lose my license. Like,
Yeah.
I'm sorry, but I have to ask like these questions about blood thinners and antibiotics, and they finally calmed down and accepted that. But it was just fascinating to me that like I'm doing this to be protective of you, to make sure that this is okay. So we have to have that consult, and then we can move forward. It's sort of like a miniature exam evaluation, if you will.
Okay,
Yeah.
excellent, thank you.
Yeah.
What about your other services, like you said you have, massage?
Yep.
Bodies?
Yep.
Is that incorporated into the plan of your device as well?
Yeah, so massage, we have a massage therapist here still. He is going to school for another degree. So when he finishes that, I have a feeling he'll be exiting the massage profession. So probably won't have a massage therapist here for too much longer when he's done. So we do have that. And then in physical therapy, we will use our hands. We call it manual therapy, but a lot of it is similar, like myofascial release or like joint mobilizations. So we will do some of that, or like cupping. We have so we have different and Grass did like different tools that we use with soft tissue stuff. So we will put that in part of the visit if we think that's needed. And then like the dry needling. The Pilates, we have our PTA teaches a mat class, and then she also knows how to use the reformer. So I use the reformer sessions. So that's usually outside of physical therapy. We have a reformer on the outside of the building. So if a PT is working with a spine client, it's usually mostly our spine people, and we want to go over and use that equipment during the PT visit and start to see if they can handle more load, more of that kind of movement patterns. We can go and then we would just build that as part of the visit. It's physical therapy trying to use a reformer, so it's available. But then from there, a lot of people will transition to the Pilates stuff. Yeah, but good questions. I forgot to bring those up. Yeah. There's a lot of things that we have now. and a thing like this, it's always hard for me to know how much to cover, right? So.
I was thinking of myself particularly going through the slides that you went through. I'm like, well, yes, I've done that. Oh, and done that too. Oh, I might be that one.
Yeah.
So I'm like, how are you going to narrow it down to
Yeah.
what actually is my problem? By the way, I do have an appointment coming up in May.
Good. I would say do the evaluation and start there, and then we can pinpoint what is high priority and where to focus. Because yeah, I mean, you could have 3 or 4 different body parts going on, and we just have to prioritize and go from there. Yeah. So we can help navigate that because it can be a little overwhelming.
Yes. I just want something like this at my job.
Yes. So start with some shoulder blade squeezes, get up and walk around, chin tucks, throw a stretch. Those are easy to throw in. I try to tell people, like, think of it as like exercise snacks, right? Like, do these as like, because they're not hard, you don't have to do that many of them, and if you just kind of treat it as exercise snacks throughout the day. Even doing chair squats, they've done studies where, like, if you get up and do 10 chair squats at, like, 5 different times during the day, you're not going to suffer as much of the sedentary side effects if you just sit to your chair, glued to your chair all day. So I'm like, exercise snacks. If you can adapt that mentality, especially if you're not a person who really loves to exercise. I have a lot of patients who just like, I didn't grow up with that. I'm not going to go to the gym. I'm like, fine, let's just talk about exercise snacks and movement and walking, and when can we just move a little bit here and a little bit there.
Oh, my job, I sometimes don't have time to that.
Right.
So that's gonna be
I
hard for
get
this.
it.
That's it.
Yeah, so maybe some chin tucks while you're there. Shoulder blade squeezes, shoulder rolls. You don't have to get out of your chair, but at least you did that. If you drink lots of water, then you have to.
Yes.
You have to. You can't, yeah, it's like you want to have exercise. Yeah, that's what I tell people. I'm like, get your thing of water and just start chugging it.
Yeah.
It's the only way I get my water intake. All right, let me see if anyone else has asked questions in the chat. No?